Yeah, it's really similar, and in fact this drug was often used as part of the, sorry for everyone else, so the question is Lemtrada or alemtuzumab similar to the hematopoietic stem cell transplants? So a hematopoietic stem cell transplant is when you have your stem cells harvested, they're sitting external to your body, and then you're irradiated or you're given chemotherapy to knock out your immune system, and then you're given your stem cells back. So alemtuzumab, which is this drug, was initially used as part of those transplants as well. So it's been difficult looking back in the literature to see what was the effect of the Lemtrada versus the stem cell transplant. But the stem cell transplant does go a little bit beyond in that you sort of can get a much more of an obliteration. And for some reason, the autoimmune disease doesn't seem to occur with the hematopoietic stem cell transplants. The benefit to the Lemtrada is that it doesn't have the sort of mortality risk so much. But again, it's an upfront risk like the hematopoietic stem cells. So it's very similar. And so for patients that talk to me about going to places and having the hematopoietic stem cell transplant done, I would personally prefer people have this drug because it's been in phase 3 trials. We know how effective it is, and it doesn't have that upfront mortality risk to it, rather than the hematopoietic stem cell transplant. Where it fits in MS remains a bit unclear because it's never been trialed. So people haven't been randomised to Lemtrada or bone marrow transplant or Tysabri and bone marrow transplant, whereas people have been randomised to beta interferon versus Lemtrada, and we know that it's way more effective, and we've got a really clear idea of the side effects. But that's a really good question. Yeah. Any other questions? Yep.
Are any of these drugs that will have any benefits to people with progressive disease?
So that's another really good question. Oh, the question was, are any of these drugs beneficial to patients with progressive disease? So the current answer in 2015 is not thought to be. But in saying that, the Tysabri, the natalizumab, is currently being trialled in progressive disease. And interestingly, the alemtuzumab or Lemtrada was originally trialled in patients with progressive disease. And what was recognised is that in most of those patients, the people with disease progression, the progression continued despite the drug, but they had no more relapses. And so that it jumped ship to a relapsing remitting disease treatment. But in saying that, there is some suggestion that that jump might have been a little bit hasty, and that there are some patients in that original cohort, I think there were like 25 people that with progressive disease that started off with that drug, that actually, rather than their disease getting slowly worse, actually plateaued. So I think the role of these immune therapies on progressive disease is still not known, still unknown. But I would watch that Tysabri trial very carefully and see if you can get an idea of whether they may work. And then the next question is something even more powerful like Lemtrada. Does, the company that owns this, if there's a signal from that Tysabri trial, I imagine they'll do one in progressive disease. Yeah, but it's hard to know. If you haven't seen your neurologist and you've been waiting for an eternity, but you've had 2 relapses the year before, then that's okay as well. So it's 2 relapses in 2 years or 1 relapse in the past 1 year. So that's the relapse criteria. There's disability criteria. So in New Zealand, really for funding reasons, the Pharmac had to draw a line, and the line got drawn at an EDSS score of 4. And to have an EDSS score of 4, you need to be able to walk 500 metres. So for those of you who have had relapses and are keen to get on treatment, the best thing you can do to ensure that you've got that in the bag is to make sure that you keep your walking going, even if it means finding a physio, thinking about the medication famotidine that treats mobility, and make sure that you keep going with your walking, so that if you have a relapse event, you can say to your neurologist, yep, I've had a relapse and I know I can walk 500 metres because I'm actually walking 800 metres. Before this happened, I was walking 800 metres, or I'd walk, I could walk a kilometre or something. So if you yourself know how long you can walk, then when you have a relapse event, it's kind of very clear for you and your neurologist. It's amazing how people who have quite significant disability can still manage to walk that far. You need to be able to do it without aid or rest. So for those of you that are needing a walking stick, it's probably something that you'd want to do with the help of a physio. So the physios at Rope Physio or a neurophysio, or maybe even through the MS Society may have contacts to help with that. It's not something you'd want to start doing by yourself, but if you want to have a goal in terms of your mobility for treatment, then 500 metres without aid or rest is what you would need to be able to do. And that is, for some people, that cutoff is really very unfair, and their disease would be treated with these types of drugs, but that's unfortunately just where the line has been drawn. And it's not drawn like that in any other country. It's something that New Zealand has decided to do. So it probably for some of you seems phenomenally unfair, but unfortunately it's what we're working with at the moment. It may be something that changes with time, but as of now that's the current level. In the good old days before November 2014, we had the lower limit disability, so you used to have to try and make yourself have disability in order to reach criteria. But now you don't have to make anything happen. You just need to be as normal as possible. As close to zero is fine. And I used to have patients that were very confused come and say, what is it that I need to have and what do I need to be like? So now it's great. We just say, how you are is fine as long as you can walk 500 metres. So it's much more straightforward in terms of reaching the mobility disability criteria. The other thing, and why Therese is asking this question, who's had an MRI lately, is that there are very strict MRI criteria, and they are also difficult sometimes to get around. So I've had some patients who've been really disadvantaged. They've been with a neurologist who might never have done an MRI. For some reason, so they've been diagnosed, and maybe I don't think they were diagnosed pre-MRI era, but for some reason they haven't had an MRI. So then they don't have a baseline MRI, and what you need is to show that you have new disease activity on an MRI scan. So for those of you who had an MRI scan back in 2007, who are going to get on to treatment, then I wouldn't get another MRI, because between 2007 and now, you're sure as hell likely to have had something happen on your MRI scan. So I wouldn't get another one now and wait for a relapse and then get another one. All you need to do is wait. If you can walk 500 metres, wait for a relapse, then get an MRI and show that there's been disease activity. For those of you who had an MRI scan in the UK and you can't get it, and no one knows what that showed, and you're thinking that you might have a relapse in the next year or two and you want to reach criteria, it would be a good idea to self-fund an MRI as a baseline so that you've got something to compare to. The other way that you can show activity is if at the time of your relapse you get an injection of the contrast and the lesion shows up like a light bulb, then that would be proof that you had activity. I hope that makes sense. So you need a comparative image, or you need a gadolinium enhancing lesion on a scan to reach criteria. And some people, unfortunately, are at a disadvantage with the MRIs. For other people, it's great that in New Zealand people don't get MRIs, because all you need is one new lesion or two new lesions since 2007, so it's not difficult to reach that criteria for most people. So you need your MS diagnosed confirmed by a neurologist, and must include MRI confirmation. Patients must have clinically definite relapsing remitting MS. So this is another bit that's been phenomenally frustrating for some patients, and still leaves me having conversations like I was having pre-November last year, where we're saying, yes, you have MS, yes, you have activity on your MRI, but unfortunately we can't fund treatment, and that's because if you've only ever had one attack ever, so we're not talking an attack in 2007 and an MRI in 2007 and now another relapse, we're talking first ever relapse event, and patients in 2015 can be diagnosed with MS just after a single event, as long as they reach MS diagnostic criteria on the MRI scan. But those people aren't eligible for funding because they need to have had 2 events ever. So you need to have 2 events, and that's what's meant by that clinically definite MS. EDSS score, 1 relapse in 12 months, 2 in 24, evidence of the MRI activity on a scan within the past 24 months. So that, as I said, evidence is either the injection of contrast lighting it up like a light bulb, or a new T2 lesion or lesions compared to a previous scan. And that scan can be 2007, they don't seem to mind.